good afternoon, everybody. Thank you for joining us. It's my pleasure to introduce our speaker today. Blester is currently the Group Clinical and Quality Manager at Promisia Healthcare, leading major service improvements like award-winning care programs, infection control initiatives, dealing with audit preparations, and all the good stuff. So he'll be talking about UTI management in aged care. There will be a short question and answer session at the end of the presentation, but you can post your questions anytime using the Q&A function, or for any engagement throughout the session, just use the chat box. And over to you, Bless.
Thank you, Rebecca. And I just want to correct that one, Rebecca. I'm not officially the group clinical and quality manager, but I'm the clinical and quality manager for the group. There's a two different.
Okay.
So good afternoon, everyone. I'm Bless. I work for Promesia Healthcare, and today we'll focus around discussing optimizing UTI management in aged care. Managing UTIs in rest homes presents unique challenges and requires multifaceted approach to ensure effective treatment and prevention of urinary tract infections. UTIs are prevalent among older adults due to factors such as decreased immune function, coexisting health conditions, and increased use of catheters. As we all know, UTIs are a common cause of antibiotic prescribing in aged residential care. Okay. At the end of this presentation, the participants or us will be able to gain adequate knowledge and skills on the fundamental principles of managing urinary tract infection in aged residential care setting. Specifically, identify atypical symptoms of UTI, sorry, that's a typo error, in older adults, recognize the importance of accurate diagnosis, articulate treatment strategies to UTI, focusing on responsible antibiotic use, and lastly, describe preventive measures to reduce UTIs in aged care. Guys, I would like to apologize. I'm a bit under the weather, and I'm a bit sick. So my apology with my voice. So what we have here is the urinary tract. So UTIs are infections anywhere in the urinary tract system. So the urinary tract is composed of upper urinary tract, excuse me, and lower urinary tract. These are the organs that makes your urine and remove it from the body. The urinary tract is divided into these two parts. The upper, which is composed of your kidneys and ureters, and the lower urinary tract, which is composed of your bladder and the urethra. So it's very important that we are able to distinguish a patient having a symptomatic UTI and asymptomatic bacteriuria. It is important to ensure that these are important to ensure that residents are treated appropriately. So it's so important to understand the anatomical position of the anatomy of the organs involved in urinary tract infection, because this actually explains why why UTIs are more common in women than in men, considering the shorter length of their urethra compared to the length of the urethra of your male of the male urethra. Symptomatic UTI are diagnosed clinically, and they can occur anywhere in the urinary tract system. So if it occurs in the upper urinary tract system, it is what we call pyelonephritis. And if it occurs on the lower urinary tract system, it is commonly termed as cystitis. Are the symptoms that we can, these are the symptoms of the bladder infection, the urinary tract infection of the lower urinary tract, which includes pain or burning while urinating, which is medically called dysuria, frequency in urination, feeling the need to urinate despite having an empty bladder. It's what we call urgency. Bloody urine, hematuria, pressure or cramping groin or lower abdomen, or commonly called suprapubic pain. Symptoms of a kidney infection can include, so kidney infection is otherwise known as your pyelonephritis, which which is more severe compared to the infection of your bladder or cystitis. So the symptoms of these are fever, chills, lower back pain, or pain in the side of your back, costovertebral angle tenderness, nausea, or vomiting. So symptomatic UTIs are clinically diagnosed and can be confirmed by a laboratory test. And while your asymptomatic bacteriuria or the isolation, I'm just gonna move this one. Wait. Or the isolation of the bacteria in a sample of appropriately collected urine without associated signs and symptoms of urinary infection is a microbiologic di- diagnosis confirmed by an isolation of bacteria and no associated signs and symptoms of a UTI. Treatment of ASB contributes significantly to antibiotic misuse in the in aged care setting. So how do we diagnose UTI? We diagnose UTI using these by following some guidelines. Effective management of UTI includes timely diagnosis. UTI is diagnosed with signs and symptoms and may be confirmed with laboratory testing. So your clinical symptoms includes A, B, and C. You can see there people without urinary catheter experiencing situation like your dysuria, your fever, or two or more of the following: suprapubic pain, visible in blood, or your hematuria, new increase in continence or urgency or frequency. And the second one, and this has to be confirmed with your laboratory, may be confirmed, not must, but may be confirmed with your laboratory testing for um, microscopy, culture, and sensitivity using the bacterial count. So always remember, guys, when you send samples, urine samples to the lab, that it's very important to put clinical details or clinical information because the lab that actually helps the laboratory personnel process the sample and creates a clinical picture based on your clinical details provided and the samples provided. The frailty care guides provides us with a flowchart of decision making for treatment of medically stable residents in age residential care. It's a decision support tool they have to help you decide treatment pathways for your residents having symptoms for UTI. Patients should not be screened and treated for UTI unless they are symptomatic, except in pregnant women and prior to urologic procedure. So for someone having ASB or asymptomatic UTI, they shouldn't be they shouldn't be treated with any antibiotics. So how do we diagnose people who cannot report symptoms? In situations where residents cannot report their symptoms, those with dementia or communication issues, the nurse will need to observe for changes in cognition, behavior, function, and vital signs to identify deterioration. Remember that diagnosing UTI greatly relies on to the symptoms presented by your patient residents or yeah. So The next slide shows us the different tools to uh, to classify symptomatic urinary tract infection. So, in diagnosing urinary tract infection, so you got the tools Lloyd criteria, McGear's criteria, and it says there, and it further classifies if someone has a catheter or without any catheter. Question: the diagnosis of UTI is made if the urine culture is positive, even if the absence of symptoms consistent with UTI. The answer is that the diagnosis of UTI should be made when residents have signs and symptoms of a UTI. A positive culture in the absence of signs or symptoms of a urinary tract infection indicates asymptomatic bacteriuria, where we discussed that it doesn't need any treatment. The next slide shows you the different syndromes and the lab tests that they're tested, and the different signs and symptoms of these syndromes. Most of these syndrome tested positive on both, not most, but all these syndrome tested positive on both urinalysis and culture. So even if you are asymptomatic, you can still get a positive test for urinalysis and culture, even if you don't have any signs and symptoms. That is why it's so important to actually follow the criteria of the McGear's criteria for diagnosing UTI to be able to have the right treatment pathway for your residents. Or what are the treatment strategies and or the treatment process for urinary tract infections in aged care setting? First, it's so important for us to identify the symptoms and document the symptoms. Next, contact the GP or nurse practitioner for the treatment plan. Followed by collect a urine sample for culture sensitivity before administering any antibiotic. A clean catch urine or collect through intermittent catheterization and keep specimen refrigerated until processed by laboratory. Avoid false results. You have to do, while you're still collecting and sending the sample to the lab, you might notice that your GP is actually doing some empirical treatment with your resident based on the symptoms that is presented by your resident. So even if you haven't received the result of the lab that you sent, the sample that you sent to the lab, a resident can have or can be started with antibiotic when the resident presents signs and symptoms of urinary tract infection. Administer prescribed antibiotic treatment. Then when the result comes, it's so important, when the result of the laboratory is so important to check antibiotic matches, sensitivity and sensitivity report. Check bacterial count within the range and described in the decision flow chart that was shown previously. Then contact the GP and NP if bacteria are not sensitive to antibiotic, and so that appropriate treatments can be provided. Or some of the antibiotics used in treating for acute uncomplicated cystitis. However, in New Zealand, our first line of antibiotics use is nitrofurantoin, and trimethoprim has been removed as part of the um, first line antibiotics for empirical treatment. This is because there has been a pattern of there has been a pattern of resistance that has been noted on the susceptibility report in New Zealand. Some alternative medicines that's been used are your cephalexin as well. But the first line is nitrofurantoin or your modified release macrobid. People ask why is it it's nitrofurantoin? Because based on the susceptibility report, most of the urinary tract infections are sensitive to nitrofurantoin, which actually helps with managing urinary tract infection that is caused by E. coli. So this is the randomized clinical trials of treatment of asymptomatic bacteriuria in elderly population. A prospective randomized clinical trials of antimicrobial therapy or no therapy for elderly residents of long-term care facilities have reported no benefits of screening for treatment of asymptomatic bacteriuria. So this is a data shows on a RCT randomized controlled trial study. Oh, sorry. That shows that there's no benefits on treating asymptomatic bacteria in elderly population. Urine cultures may not be needed in cases of uncomplicated cystitis unless patient fails empiric treatment. So appropriate use of urine cultures. Sometimes it has been a practice actually of it's not uncommon for an aged care facility to actually keep sending urine sample to the lab, even if the patient doesn't meet the criteria for symptomatic urinary tract infection. So dysuria, urgent frequent urination. These are the appropriate use of urine culture. You get when the resident got dysuria, urgent or frequent urination, suprapubic pain or tenderness, flank pain, fevers, and the inappropriate use of urine culture includes when it's odorous, cloudy, or discolored urine in the absence of other localizing signs and symptoms. Because there are other conditions that can actually present odorous, cloudy urine, just like your sexually transmitted infections. They can also present odorous, cloudy, and discolored urine. Reflex urine culture based on your analysis results, such as pyuria in the absence of other indication. Urine culture to document response to therapy unless symptoms fail to resolve. Or just sending urine sample to screen for asymptomatic bacteriuria. Preventive measures to reduce UTI. These are some of the preventive measures identified in the literature to help reduce with the UTI. It is highly encouraged that residents take at least 1.5 liters per day, depending on their condition as well, because some of the residents have got cardiac problem and you don't want to cause fluid overload with this type of residents. Considering removal of dwelling urinary catheters, if possible, continence assessment, and if necessary, well-fitted products, hand hygiene, both resident and care provider, avoiding constipation, vaginal estrogen, consumption of cranberry products. So the latest research actually says that there's a benefit of using cranberry products as part of prophylaxis for UTI. the MV140 vaccine. So there's a vaccination available to help treat recurrent UTIs. When we say recurrent UTIs, these are urinary tract infections that occur 3 or more in the 12 months. And lastly, the methionine hyperate, hyperex. Hyperex. I just want to share to you guys a quality initiative uh, by one of our care homes in Christchurch, Alvin's house, and in managing urinary catheter, blocked urinary catheters and UTIs. So um, before they had a total of 65 incidents of urinary catheter block, and that was recorded for a period of 6 months between September 23 to February 2024. And this prompted the team to actually look at it and review it, and if there's something they can actually do to address this. And they initially, so the aim of the project was to reduce incidence of blocked urinary catheters over the 6 months, to reduce UTIs, and to reduce the use of antibiotics and improve the comfort by less frequent catheter change. So what they initially do was, just like anyone would, they started education and education in service around hand hygiene with the team. Discuss around UTI, IDC management, uh, and hydration education session was also delivered. But still there were no improvements with their block catheter. So they've evaluated catheter products in comparison with other products, and reached out to Amtech sales team for information around the Bard BioCat Foley catheter brand. And they've actually trialed the Bard BioCat, which is a catheter with ultra smooth hydrogel coating that increases patient comfort and can resist bacterial colonization and incrustation, as well as reduces urethral irritation. And after they've actually changed the catheter that they've used, they've seen a significant drop with their block catheters and UTIs in the care home. So as you see, in the month of June and July, there were no longer UTIs, both for IDC and non-IDC, for those residents that have catheters. No, it reduces the use of and the total number of UTIs were reduced on this from January to July of 2024. The same time with their antibiotics use. So the number of block catheters reduced by over 55% in 6 months. There was a 100% reduction in UTIs. And so the final data analyzed and evidence in the graph did not include that had passed away, so their block catheters and UTIs were not included in the graph. This evidence that decline in the block catheters use were not due to residents leaving the facility. They included the new residents to increase the number of residents with IDC and SPC to a total of 15 residents in July. And there were nil UTIs for the 15 residents during the month of June or July. And there were no use of antibiotics for UTIs for these 15 residents during the months of June and July. Thank you so much, guys.
Thank you, Bliss. Has anyone have any questions for Blister? I think you must have explained yourself really well because there's no questions at all.
I'm just really sick.
No, that's I think that's really thank you very much for
So
sharing.
there's a
Oh,
question. MV140 is that available for free? Yes, that's funded. So give me one quick minute. I'll just put my notes, making sure that it's funded. Yeah, the MV140, that's a funded vaccine. Let me just double check. In my let me just check. To check for funding, you can actually go to NZ formulary and just check if the vaccine is funded or not. I'm sorry, I stand corrected. The MV140 Euromone unapproved, not funded, but it's the most commonly used vaccine for UTI prophylaxis in New Zealand. Yeah, sorry guys, it's not funded. The pump used at Aldrin's house was Bard Biocast Foley Catheter, BARD Biocast. You can ring Amtech for this. So previously, we actually, like when I started at Aldrin's house, we were sending almost every week someone to the DHB for a block catheter. Like they're changing the catheter so often because it gets blocked all the time. So the previous clinical manager actually sat down with the team, looked at it, and reviewed it. They started educating around hand hygiene, UTI management, catheter management, but still it's not working until they reach to a point like maybe it's the catheter. So they actually uh, reach out to Amtech and trial the Bard Biocath, and that actually made significant difference with their block catheters and their management and with the rates of their UTI.
so Jillian has written that some of the research you showed was about 20 years old. Do you think there's any changes in the same data set during the time?
Which data set, Jillian? So 2005, which one is that one? Which one is that, Jillian? And this is just the randomized control trial. Thank you for raising that one, Jillian. There's no late. This is the last randomized control trial that study that has been done for the treatment of the symptomatic bacteriuria elderly in population. I do understand that it's dated 2005, but that's the latest randomized control trial in the field of treating asymptomatic bacteriuria in elderly population. So this calls for researchers to actually jump in and do a research around treating asymptomatic bacteria in elderly population. Yeah, so that's the latest you can get, Jillian, on the literature for a randomized control trial.
There's also another question. Are you still using urine dipstick if your residents have UTI symptoms?
So there's a place for urine dipstick though, but it's not recommended per guidelines um, for elderly, for the population group that we looked after. We use urine dipstick if you want to look at protein, because part of your urinary tract, you have to remember, your urinary tract involves your kidney. And once there's a protein in your urine, you use a dipstick, then you start questioning, what is the kidney's function? Is my patient or resident experiencing acute kidney injury, which is quite reversible? I mean, like, you do dipstick, but you don't test it for nitrates. You don't test it for pyuria or presence of your white blood cells, because the table I showed you earlier, where there's the three different syndrome, if you dipstick that one, even for those three different syndromes, most highly likely they will test positive. It doesn't change your treatment modalities for a resident experiencing UTI. UTI is diagnosed on symptoms based on the guidelines for diagnosing UTI. It's symptoms like the signs and symptoms of UTIs is the most important thing that nurses should be able to pick up in aged care setting. Timely identification of these symptoms matter a lot for your patient not to deteriorate quickly, so you can provide early interventions.
Oh, thank you very much, Blesta. Anyone else has any other questions? Oh, I think that is all. Thank you very much, Blesta. Thank you everybody who has attended. Have a
My
good
apology,
evening.
I'm sick. Yeah. Thank,
I think you explained yourself really well. Yeah. Thank you very much, everybody.
thank you. Yeah, thank you.